Welcome to the Wow MD podcast, where in each episode you will get in 30 minutes or less valuable pearls about holistic wellness, anti-aging, hormone therapies, beauty trends, and other facts you should know about our medical healthcare system and your health that no one is telling you. My name is Dr. Mirala Chernayanu. I am a conventional board-certified OBGYN physician who, after the loss of my father due to a careless and uncaring medical team, decided to retrain and seek certification in anti-aging and restorative therapies. What I know, I am happy to share with you. This week's episode will aim to address optimal estrogen levels in women based on age, as well as optimal levels during replacement therapy or estrogen therapy after menopause. By the way, I'm going to start by saying how grateful I am for you coming back week after week to get more information and more pearls about health issues and the various topics of health, hormones, and beauty that I offer by means of the Wellness Optimizing Warrior MD podcast. Before I start talking about estrogen levels, you, my dear listener, will need to listen to this very short recap on what happens with estrogen levels during a natural cycle. Many women do not understand the natural cycle and what really happens, but it is important to understand because the estrogen levels will vary from day 1 of your cycle until day 28, or whenever that cycle will end for you. And estrogen level measurements will yield different results and show totally different numbers based on what time and what day of the natural cycle you were when you got tested. And if you're menopausal and you're like, why am I wondering? I don't have any more cycles. Well, that is a reference range that's very important for you to understand when we talk about optimal estrogen levels during postmenopause estrogen replacement. Measuring estrogen when you are on estrogen therapy after menopause, it's a lot easier because the variability of estrogen levels only depends on a couple of factors, which I will talk about. So coming back to the natural cycle, when a woman is still ovulating, her cycle starts on day 1 with very low estrogen levels. Most likely, the estrogen levels will be around or under 50. If the ovaries are healthy and they have a good ovarian reserve of eggs, and if the communication between the brain, the pituitary, and the ovary is normal, then your ovaries will start responding pretty quickly in the first 3 to 4 days. By day 5, 6 of your cycle, the estrogen production from the eggs that are being recruited for that specific cycle will rev up and start increasing estrogen levels to a peak that is reached when ovulation is triggered about day 14 from day 1 of your period. When a woman has a normal functioning ovary that is capable of ovulation every cycle, then the estrogen levels will peak and reach a maximum around ovulation time, which is usually around day 13, 14, 15. That is the day from the beginning of your period compared to day 1, right? And the beginning of your period marks day 1 of your cycle. So what is the normal peak level of estrogen around ovulation? Let's start there because that's very important. The level of estrogen at ovulation, which is the peak estrogen level, is highly dependent on the quality of the egg that has been recruited and released. The quality of a woman's eggs starts declining after the age of 35, whether we want it or not. And it declines drastically after the age of 40. Now, I should have known that, but I wasn't really into all of this. And this, believe me, it's not being taught in neither medical school nor residency. So after the age of 35, and especially after the age of 40, your best eggs have already been recruited and either were matured and released, or they were part of a cycle of recruitment that happened month after month from the age of 12, or whenever you had your first period, until the age of 35, maximum 40. Believe me, I'm not off topic. This is important. The peak level of estrogen for a 20-year-old at the time of ovulation, 2025, could be as high as 300 or more. Anything between 100 and 300 is likely to be within the normalcy window determined by the lab. So that's a pretty wide range, 100 to 350. Now, in the past couple of episodes, when I discussed testosterone, I explained and I discussed normal range versus optimal range. And these are two very different things. Normal range is established by the lab, probably based on a statistical analysis of the most frequently performed and obtained test results from a large group of women in a specific age group for a specific time of their cycle, whereas optimal levels would be the levels at which your body would perform optimally. And that will vary, especially where estrogen is concerned, because it's depending on the timing of your cycle and your age, as well as the quality of the egg that is being recruited. So let me talk a little bit about the extremes of the normal range during ovulation, 100 on the low end or under 100 and 350 on the high end. So you can understand better what I'm talking about. If I'm looking at a 25-year-old who's healthy, I'm not suspecting PCOS or any abnormal ovulation problems, then I will not really be very glad or excited to see estrogen levels around ovulation time of 100 or under. From an optimal standpoint, that is way too low. It will trigger alarm bells about the quality of the egg or about the fact that she might not even be ovulating. So I would really like to repeat the next blood draw in a week and check her estrogen and progesterone levels for the same cycle to understand whether or not there was ovulation and she just took a little bit longer to get off the ground, so to speak, with that specific cycle. I will talk about progesterone in a little bit. This is all dedicated to estrogen for the time being because this specific hormone is such a complex, disputed, and controversial hormone, especially once you no longer make it. So I'll talk about estrogen only for now. So again, 25-year-old, 100 or less, not good for estrogen level during ovulation. Now, on the other hand, if you're a 40-plus-year-old and I'm seeing an estrogen level around ovulation time of 350, that will raise some alarm bells regarding the process of estrogen elimination, or whether or not we're dealing with an ovarian cyst that's making a much larger amount of estrogen that I'm expecting to see for a woman who's not supposed to have that much estrogen. So the discussion of how important data interpretation is when we're taking into account estrogen levels that are at the extreme of the optimal functioning range of normal also points out that between the values of 100 or under and that of 350 or more, there is a very wide range of possibilities. And that is why the doctor who interprets your data should be someone that has at least some basic training in hormone management. Believe me, it is all fine and dandy if you are a primary care doctor or internal medicine doctor, maybe even your psychiatrist, will humor you and test your hormone levels and then tell you they're perfectly normal when you don't feel normal. You need to understand that unless the doctor has had hormone training, he or she will not be the best person to look at your hormone levels. Even worse, you might be told they're normal and you're going to believe it. And then you're like, I'm going to have to look somewhere else. There's no problem with my hormones. You really need to review and discuss your situation, your clinical picture, and your labs, because they need to be taken together with someone who specializes in hormone management and hormone balance. So let me address the mini elephant in the room, which is the limitations of doing snapshot one-time blood testing. We have significant limitations around interpreting estrogen levels accurately for a woman who is cycling because her levels will possibly vary and be very different from cycle to cycle. It is true that a healthy 20 to 30-year-old woman will be expected to have a reasonable predictability around her ability to respond to the brain impulses in the same way consistently and persistently between the age of 20 and early 30s. So her cycles could be very similar to one another. However, in a more mature woman, let's say late 30s, early 40s, who has had a few children or has never had children, once that woman approaches the age of 35 or goes beyond the age of 35, now the quality of the eggs that are being recruited month after month starts to falter, dwindle, and decline. So will the predictability value of testing hormone levels. One specific cycle, just a random cycle when you do your annual testing. And based on that, now we need to make predictions about the rest of the cycles or future cycles. You might make false predictions. What do I mean by this? Well, I always caution my patients, especially when I test their hormones after the age of 35. I might say something like, well, yes, it is true. Your hormone levels look rather optimal, but I cannot guarantee that this is happening every cycle. And taking your lab values into the clinical context of your symptoms might get us very close to the truth or to the reality of what's happening with you. It is impossible for a woman to have her hormone levels tested every cycle or 3 cycles in a row in order to understand the pattern. Sometimes that is necessary, and it is being done, especially in the course of fertility treatments. Outside of that, testing multiple times a year during different cycles at different times throughout the cycle is not feasible. It's not practical. It will be very costly and totally inopportune for someone's schedule. Again, it will require testing multiple times and having multiple doctor appointments to talk about the data. Clearly not practical, and nobody uses that. Now, there's one way we can extract data and circumvent this variability of hormone levels, and that is by recommending a test that's looking at estrogen metabolites. Now, the amount of estrogen produced by the ovary month after month will predictably, due to genetics and epigenetic factors, convert into various metabolites. By measuring these metabolites, we can deduct what your overall estrogen exposure for a specific hormone like estrogen would have been for a reasonable amount of time, maybe days or weeks at a time, so we don't have to test all the time, like blood testing. This is a urine test. Now, this type of testing has been around for over a decade, is gaining more and more traction, and has significant value, and is looking at estrogen, testosterone, and progesterone, including cortisol and DHEA, at their metabolism in a way that blood testing is not able to do. Again, blood level testing is great, but it is a snapshot view, just like you take a picture, a photo. You're snapping a photo of a moment. It does not capture the entire moment. A video will capture the entire moment, and pretty much that is what metabolite testing is. A little bit of a capture similar to a short video. It captures the essence of what happens to the hormones in your body and gives you an overall view, not just on the levels, but what are the pathways that these hormones ultimately take in your body, favorable or unfavorable. This is very important when we talk about risk cancer and you have lots of family members that have had cancer, but you do not carry the mutation and you want to know if you're at risk to get it. I do like to offer this type of testing for my patients in the practice. And I do encourage for women that are in menopause, undergoing estrogen therapy at least every few years, maybe yearly for women who are in perimenopause, especially if they are using hormone therapy. Now, the major downside to this type of testing, it takes a while to get the results back, but that's not the major downside. It is the cost. It averages $500 or more. So I want to move on and make another point. I talked about optimal estrogen levels around ovulation, and I explained why a low level around ovulation in a young patient signifies a problem, and a very high level in a 40-some patient would signify another problem. But I want to talk a little bit about FSH. FSH stands for follicular-stimulating hormone. The pituitary makes FSH as a response to low estrogen. The lower your estrogen is, the higher the FSH will be, as the pituitary, under the guidance from the brain, will go nuts trying to make your ovary to respond and make estrogen. But once your ovary has run out of eggs, it can no longer make any eggs or estrogen. So FSH will go up. FSH is one of the best indicators for overall ovarian function, outside of anti-Mullerian hormone tests, which indicates ovarian reserve. Another topic for another day. Now, if FSH is low, under 8, that is likely a very reliable indicator of normal ovarian function and at least average egg reserve. Even though the quality of the eggs means nothing and FSH does not give you any information about that. FSH levels in a woman under 40 that are raising slowly and gradually, and they're just slightly above 10, or between 10 and 15, that already indicates diminishing ovarian capacity. And FSH levels over 20 indicate failing ovarian function with significant diminishing capacity and reserves. If a woman is in her 40s and she still has periods, or in her 50s. FSH levels over 30 in a woman past the age of 50 is indicating impending or existing menopause. So this specific hormone is very valuable to test alongside estrogen testing. It should be part of the testing panel that is ordered. I really do not understand why some doctors test only FSH and some only test estrogen levels. They should always be tested together, as the estrogen level only is just a very simple snapshot of what is happening during that day and the time of the day when it was tested, whereas the FSH gives a more panoramic view of overall estrogen levels for the past couple of weeks. So please make sure they're tested together. And when you go to the doctor and ask for hormone testing, they should be ordered together. You should also know that FSH levels, the follicular-stimulant hormone levels, are very stable. It takes weeks, like 2 to 4 weeks of a change in estrogen exposure for the FSH levels to respond. So it doesn't really make sense to repeat FSH levels earlier or sooner than 2, 3, maybe 4 weeks. And remember, FSH is released by your pituitary gland in response to low estrogen. It's the drive from your pituitary that talks to your ovary and tells it what to do. Sometimes the FSH is really low and you have no estrogen. That means there is no drive and the ovary is just stagnant and awaiting instructions that are not coming. Now, I like to call FSH the menopause hormone because after the age of 50, it's a very reliable menopause indicator, just as it is a very reliable indicator of how effective your estrogen treatment is after menopause. Let me explain a little bit more what I just said. Because if you are using estrogen post-menopause, you should know not just what your estrogen level is, but what is your FSH. And very few women care about FSH, or they come in asking, hey, what's my FSH level? No, all they ask about is my estrogen level normal? Well, as I said, when you're young and healthy and you have plenty of estrogen, your FSH levels are going to be under 10. As you get older and there's less and less estrogen able to be released from your ovary, especially when there are prolonged periods of time when the ovary does not respond to the brain and the pituitary stimulation, your FSH levels will go up above 20 or more. The ovary starts responding, a new cycle starts, there's eggs to be recruited, beautiful. Your FSH levels will normalize and go down again. FSH levels below 20 in menopause while you are on estrogen therapy indicate steady, constant estrogen exposure. So let me use an example. If you are using estrogen therapy after menopause and your hormones were initially tested, let's call that the baseline test, before you even put any estrogen in your body. You had the symptoms, you came in, you talked to the doctor, you get your levels tested. Always get your levels tested before using hormones, right? So now the levels came back, your estrogen was not detectable or under 20 or 30, and your FSH was over 100, 120. Now, after using estrogen therapy, it is 75. What does that mean? It simply means you have had some estrogen exposure from the estrogen replacement therapy, from the estrogen hormone therapy, not enough to shut down the permanent, consistent, and repetitive central drive that comes out of your brain and pituitary and is trying to talk to your ovary and telling them to make more. I need more estrogen, right? Now, here's the thing. Do we really want everybody's FSH levels to be below 20, especially when they start above 50 or 100? Well, that's a very interesting question, and I'll attempt to answer it in the next week's episode. Now, let me come back to the FSH. Your hot flashes on estrogen therapy might have gone away 90% or completely. Because of the hot flashes being gone, you're sleeping better. Because you're sleeping better, you have better energy and better mood and better mental clarity. Your menopause problem is gone. Your menopause or postmenopause symptoms are gone. You are a happy customer. You keep going, and a few years go by, maybe a decade, but you slowly notice there's more weight gain, more bone loss, maybe osteopenia is getting worse. and you're like, wait a minute, I am on estrogen. Why is this still happening? You're no longer interested in sex that much. And even when you have it, orgasms are hard to come by. You might notice a couple more issues around urinary health, like UTIs, when you never used to have UTIs. You need to use a lubricant during intimacy now all the time. There's more forgetfulness, some obvious skin changes, maybe even some hair loss, etc. The weight, the bone health, the muscle mass, the vaginal health, the urinary health, these issues will keep happening even if you are on estrogen therapy at menopause or postmenopause, because your body will not get consistent estrogen exposure. And you still will have low estrogen at least half of the time, just not as low as before. You still have low estrogen, but the symptoms are no longer driving you crazy. Let me explain a little bit more. When your body naturally made estrogen, it did not make estrogen 3 days a week and no estrogen for the rest of the week. It did not make estrogen 8 hours a day and then nothing for the rest of the day. But that is what you're getting with the patch therapy or with the daily cream. When your body naturally made estrogen, it released the estrogen from your ovaries steadily and consistently over a 24-hour period. So from one day to the next day, with a small variance during the follicular or luteal phase, you had a certain amount of estrogen, but it was around the same level 24 hours a day, 7 days a week, with the exception of 1 to 2 days before your period, when your levels will really plummet, and the first 1 to 2 days of your period, or 3 to 4 days, however long it took for your ovary to respond to the brain signals, make estrogen again. So out of the 28-day cycle, you had low estrogen probably for 3 to 4 days. None of the currently existent hormone replacement methods that offer estrogen replacement, so estrogen therapy, will give you that, or will be as close to nature's evolution or God's gift in making estrogen the way your body used to make it, except one exception, pellet hormone therapy. By the nature of its bioavailability, the pellet will release estrogen into your bloodstream with each heartbeat. Every other method of estrogen replacement or estrogen therapy will release estrogen based on how you choose to introduce estrogen in your body. You apply a cream or a gel daily, you will get estrogen for less than half the day. You have a high surge for a few hours, followed by a dwindling down levels to zero, and you will have zero for the next 10 to 14 hours. You apply a patch twice a week, you get a steady rise to whatever peak level will be for that dose of the patch is different, right? Depending on the dose. And then the levels are again dwindling down in the time span of another day, requiring you to apply another patch after 3 days. You will always go down to super low estrogen. Whatever estrogen you had before, you will always go down to that level before time comes to apply another cream or another patch. Do I believe that estrogen and testosterone pellet therapy are superior to every single other hormone therapy that we have due to its steady release and excellent biological availability? Yes, I do. And anyone who understands bioavailability, which means the amount of time the hormone is biologically available to work and have effects in your body, will likely agree. Does this mean everybody's a candidate for pellet therapy? No. This is another topic for another day. Let me come back to estrogen levels as I close down this week's episode and FSH. You need to remember to always test them together because it gives you an idea of how effective the estrogen therapy you are on is going to be, especially for the improvements that require constant steady levels and constant steady exposure, like your mood, your bone mass, your vaginal and urinary health, your metabolic rate and the impact the hormones are going to have on your weight management, as well as your cognition. For all these essential functions of your body, your estrogen exposure needs to be steady and consistent rather than in intermittent spurts and surges followed by very low levels. The peaks and valleys of estrogen exposure from the daily topical estrogen application or the patch will not necessarily improve cognition, mood, unless your mental clarity and your bad mood were related to bad sleep caused by hot flashes. In that case, anything will improve your mood and your cognition because any estrogen is better than no estrogen. Now, the peaks and valleys of estrogen exposure are not that useful when it comes to improving your metabolic rate, your bone mass, your sexual wellness, and your urinary health. And does this apply to every woman? No. But if you're one of the women that have been using the estrogen cream, the patch, and you're still having issues, even though you're like, wait a minute, I am on estrogen. Why am I still having problems? That is why. There's a lot more to say on this topic of estrogen levels, so I will continue the discussion next week. Please join me for more conversation around optimal estrogen levels, especially when women use estrogen therapy post-menopause. Thank you for trusting me with your time, and thank you for listening to today's episode. If the content I provided wowed you, was helpful and valuable to either you or someone close to you, please do me a favor and leave me a review. I am very open and welcome any kind of feedback as well as suggestions on any content ideas, so please forward those suggestions to Jessica, my patient care coordinator, through our website, herabeautyandwellness.com. And I look forward to our time together next episode.